Good morning, everyone. Welcome to another Medical Minutes sponsored by the American Academy of Thermology. And today, uh, it's your hair chance to learn directly from one of the most experienced and respected pioneers in medical thermography, Jan Crawford, a BSN, MBA, and you may have seen her name in scientific journals and guidelines. You may have heard about her from the American Academy of Thermology many times, but now you get to meet her live in our medical minute session. Welcome, Jan Crawford. Thank you so much to take part today. Most of people don't know, but she is a former president of the American Academy of Thermology, 23 years of hands-on clinical experience, training many people, training many technicians, many doctors, and she is a co-author of the official AT breast thermology guidelines, the point of care guidelines, and she is in front line with when we have any specific problems with American Academy. So thanks so much, Jen, for your time and for your dedication to this academy. Please, it's for you. Thanks so much.
Thank you, Marcos. Can we do some screen sharing?
Yes.
I don't see me, so no, we're not doing it.
The green button, share.
Can you see that?
Not yet. You must should click on share.
Yeah, I did
choose
that.
the screen you want to share. Share button.
No, it's not doing that because even though I did share.
Then after share, you need to click on your desktop or whatever you want to share on your presentation. So it's 2 clicks. First of all, just go below and on the green arrow, when you see share, click it.
I did that.
Okay, and then second step, you need to click on the area you want to share. Means your presentation, your desktop.
Yes.
Now you're sharing. Yes.
Started. Okay.
And now you are review mode. Maybe you want to go to full screen, which is close, the bottom close to the 79%, just below.
Your tools are blocking my, there we go. Okay, just a minute. How are we doing there?
Yes,
There
correct.
Here you go.
Thank you.
All right, thank you, Dr. Brioche. I appreciate you inviting me to offer some information to the members. That was a very boastful introduction, and I appreciate the fact that we've worked together for many years. I met you in Louisiana at one of the annual meetings when Dr. Donna Harper and I had the pleasure of spending some time with you to discuss your utilization of infrared when you were working also on the MRI marriage with infrared utilization. Today, I am going to cover some information that I had the privilege of doing, and you'll have to excuse me because this presentation includes data that I signed a non-disclosure, so it's going to be generic. And I was asked by a wound care company who manufactured dressings to evaluate some of the standard dressings that were being in the field. and also to evaluate their particular dressing for its efficacy in wound care. So this is historical data, and also I'm going to have to show you some older PowerPoints to show you the collection information. When we look at considerations in wound care and dressing management, we have to think about the fact that dressings are used to protect against infection, promote efficient wound healing without harm or discomfort. They should be a non-adherent dressing unless there is intentional debridement use. And they should allow for gas permeability, and they are wound specific, so that for each application, we have to consider, is this a surgical wound, which is going to vary greatly from wounds that were caused by diabetic ulcers or injury. So what we're doing is looking at a dressing as its ability to keep the wound warm, moist. This aids healing. This is one of the key factors of dressings. If it's not able to keep that dressing warm, consistent temperatures, and moist, the tissue is going to dry out, and you're going to encourage loss of epithelialization of the wound bed. So what our objective was in doing this study was we were going to assess actually knee surgeries. We were looking at the patient prior to the application, and then following that patient after surgery. But as many of you know, getting an IRB in order to do some of the research that we had proposed is very challenging. Hospitals really restrict the use of data capture, and plus the patient turnaround is so quick to be able to get permission from the patient. We were trying to do it in an outpatient surgical setting, but unfortunately, we failed to achieve that IRB. So how could we do this study and get some of the data that we needed to? We decided to go to lab and use just one patient. So we were looking at 4 different dressing substrates, and we were going to evaluate the performance. We decided to set this up where we would look at baseline temperatures of the patient prior to the application of the dressing. We would look at the dressing after 16 hours. Then we would remove the dressing, and we would film how long it took to return to baseline. So when we looked at how could we demonstrate the effectiveness of a dressing on a patient with a normal leg and no wound, could we still collect data on whether or not that dressing was achieving the criteria of maintaining temperature, moisture, and also a change in circulation? So we had to look at all of the influences that could affect this study. So what criteria that we came up with was that the patient, we had to control everything about the patient that we could. He ate the same thing. He stayed in the same facility. We controlled the environment where he was staying. We filmed every day at the exact same time. All studies were done in the same time frame. The patient wore the same clothing. When we were imaging, he was in a non-disposable brief so that it did not retain the heat of normal jock strap or underwear. In his time frame, because we were going out sometimes an hour and a half after the dressing removal, the patient could keep a cotton gown on his chest. So in the lab, we set it up so that we had a pattern that he could stand on, so that we knew that the separation of the legs in the stepping gait were consistent. The camera we marked off on the floor so that we had the exact same distance every day. Nothing changed in those parameters. We controlled the room temperature at 68 degrees. And we also controlled our time intervals, so that when he returned to the office each day, he came in at a specific time. We imaged him in his clothing to see if any of the dressings emitted more heat than the other one while it was still covered. And then each dressing was applied in the same way, so that we measured off the application 7 inches above and 7 inches below the patella, so that we could have consistency no matter what substrate that we used. We had 2 cameras available to us. One was static imaging and the other was video. Now we ran these so that we could take the video strips and then separate each image out at the stage of capture from the static. However, we found that the data capture was excessive, and it became difficult to actually assess that data because of the volume. So we went to the static camera for most applications. When we started the study, we did what we considered a baseline. You can see that this is just a screen capture from the camera image information. This software limitation was that it labeled each image, so that no matter what sequence you took an image in, it put a label on, and you would have to go manually back and change the image name. So we proceeded with upper torso to lower torso. We were making sure that there was no information that was demonstrated that this person had any influencing lumbar problems that would be referred down the dermatome of the thigh. So we did this baseline to get that data. As I said before, the clothing was the same, the measurement and application of the dressings were the same. And then we would analyze the anterior on the popliteal artery, also the anterior of the knee. We did the both stepping gaits, and we would look at overall circulation. But when we did this study, each dressing did not demonstrate an effective change over the normal expected variation, even after an hour and a half when we reached baseline. But what we did find was the patient had damage to his foot from frostbite. So his left foot had poor circulation to the toes. So we decided that we could measure the toes in the next phase of the study to determine if each dressing changed the circulation to the lower limb. So all in all, we did 4 different series of these studies. The first one, we did 4 substrates. The second time that we gathered, each one of these studies took a week because of he came in with the dressing, we removed the dressing, we videotaped, then he applied a new dressing, came back the next day. So you're looking at a week each time we did a study on various dressings. So first one was 4 substrates. The second study, we expanded the parameters because in the initial imaging, we did not include the feet. But the repeat study, we did include the feet so that we could get the data measurements from the toes. The third study, we just did two dressings that were produced by this manufacturer. And the fourth study was the repeat of those 2 dressings to confirm the circulation changes. So what we're looking at today is that we've had excellent change in detectors. We have had the price point improving compared to when we did this study. This study was done well before point of care was even a concept. But what we found was limitations from the infrared software. I'd like to change over real quick on this PowerPoint, and I'd like to bring up an example of how we did this study. Like I told you, initially, when he came into the room, we looked at the patient to see the dressing was always applied to the left leg. What kind of heat escape was being demonstrated on each one of these dressings. Then after he disrobed and we removed the dressing, we analyzed the anterior aspect and the toes. We looked at stepping gaits for position and the posterior popliteals, analyzing whether or not we saw changes in the circulatory pattern. Every study demonstrated that we had consistent warmth after the removal of each dressing. But we were able to, after the fourth study, demonstrate that a particular substrate that they manufactured was actually improving the circulation to the patient's lower limb by 2 degrees. We substantiated that the patient had no temperature by measuring both oral temperature and intercanthus, so that we could demonstrate when he was participating that he was not ill and that any of the temperatures that we represented were actually consistent with what we were doing. Again, we went through all of these studies, and then in the final application determined that there was a change of temperature based on the particular dressing modality that demonstrated almost 2 degree difference. And the only way that we could really do that was, again, to go back in and say that we held the parameters. The patient had all this consistent, right down to the food that he ate during the time of the study, so that we wouldn't see any metabolic contribution from changes in diet or fat consumption, etc. We wanted to eliminate everything that we could. Today, we are not as limited by our technology. We are not as limited by our parameters. And as many of you know who are participating in what we call point of care, let me see if I can go back to this. Oh, it wants to jump out. Anyway, what we're looking at today is we are restricted by education in the field. We are restricted by regulations that don't allow us to utilize some of this equipment in the applications that we would like to, especially within a healthcare setting, because they have control over image capture, and we have to get so many releases for that patient to be able to do it. And back when we were doing this study, you have to consider the cost for the lab because of the controlled variables. Many of the practitioners, especially in the early days of infrared imaging from the 70s and 80s, lab requirements were very stringent. Everything had to have controlled airflow, temperature regulation, environmental influences. Today, many people are not aware of the restrictions that these parameters, could do to the cost of having an imaging lab. And so we're finding that more and more practitioners are moving to point of care over lab studies. But I think it's important that you know that in order to prove what we do in point of care, that sometimes we must move back to the lab controls in order to substantiate that data. Okay, get out of here. You have me back on screen.
We still see your presentation, Jan.
Yes, let me see.
All right.
Okay.
Now
we go.
Nice, nice. Very good, very good. I have many questions here to stimulate the discussion, but I will open to the others. If anyone want to start, maybe Javier. I believe you have many questions about the.
It was a great presentation. Yeah, I liked it very much. I mean, you didn't talk much, Jan, about the infrared cameras that you used. Would you like to comment on that?
Yes, the two cameras that were used, the first one was a Micron 320 by 240. The second one was an ICI, also 320 by 240. The higher resolution cameras were just coming into the availability to individuals like myself is because of cost. Now I found that both of these cameras had limitations in the software that I think still exist today. Even when we get into higher resolution, the software creates the limitations as far as how we can gather and analyze the data. I'm excited for you that you have AI now that can do that.
Yeah, totally agree. Software is a great limitation. I mean, there's been a lot of work on infrared imaging, and I would say 90% of the people still use FLIR tools, which is like a general purpose software for infrared imaging, and definitely not like a specialized software for medical imaging. So yeah, the thing is, I mean, you mentioned something that was very, very important. I mean, there's not enough market for a startup company to develop a software because there's not gonna be like, I mean, when you
volume of sales.
Yeah, exactly. I think the only company right now that has had some success with their own software is Thermo Human, which they basically focus on sports thermal imaging. And yeah, I mean, the NFL and soccer teams, I guess they have enough money to pay for specialized software, but like a practitioner, a doctor, a nurse, or a surgeon, yeah, I think they wouldn't pay much for software, but yeah.
Yeah, but there are many other companies that investing on that, and most of the software is becoming more specific. For example, Thermo is not specific for study of wounds, and especially because in wounds we have the emissivity
Changes,
differences here, and especially on the study of Jan, that is very difficult to do this study because the dressing have different thermal conductivity and specific heat, and you must have these values when you do your publication, Jan. What's the thermal conductivity, specific heat of capacity and thickness of the dressing, and this information you can have with the company that developed the dressing, and because this will influence the rate of heat retention and dissipation a lot. So it's totally different. We have many different dressings, so you cannot generalize all the dressing results with your study, for example. And And also the infrared emissivity, we know that normal skin is assumed constant 0.998, but dressing material alter emissivity and reflectivity, especially during post-removal assessment. So when you do the post-removal, you have different, there's some difference, and most of these dressing are not dry dressing, most of them are wet dressing, and just again change a lot the temperature.
In this environment, we did not have that, even though wet to dry dressings are today not accepted as a standard of care. You'll find that post-operatively, they still use a lot of, wet to dry because of cost. One of the things that this dressing had in the substrate was proprietary information that of how it was constructed. And it actually did demonstrate that it improved circulation, that this is on normal skin. It's not on a wound that would, be producing the moisture, be producing the exudate. Again, looking at actual wounds themselves, you have to consider more of the interruption of the emissivity, and humidity.
Yeah, it's very good that you start in this kind of study, and I'm trying to explain that it's not easy, and it not means that it's right or wrong, but it means that we have a lot of cofactors that can influence the results here, and it's good because we have many different kinds of research to do here, and as I'm saying, without a spectral calibration, temperature difference may be artifacts of surface emissivity rather than actual tissue thermodynamics, because here we're studying the tissue thermodynamics. And also the room temperature, you say 68 Fahrenheit, it is almost 20 Celsius degrees. And we know the heat exchange between the skin and the environment is influenced by convective, radiative flux, so the wind on the room. And for a paper that is studying the efficiency of dressing, all these factors must be controlled, and we must to take care when you compare the results of a study that was done in 68 Fahrenheit, other one in 17.2 or so. And there's no problem, but we must to identify this and understand that are little difference, and all of these will interfere on the peripheral perfusion and capillary refill of the wounds. And as Jan is showing, she started with normal skin, but imagine in a skin with infection or edema, ischemia, is much more complicated. And another point, very important, that I saw in the presentation of Jen is about the sympathetic vasomotor reflexes that we must remember of them, because the temperature, we are measuring temperature, and temperature modulation induces skin vasoconstriction or vasodilatation via sympathetic efferents. So, and when you use dressing, most of time, dressing for a long time, we must to understand that we change the reflex sympathetic response also, like a peripheral sensitization. So it's changed sometimes the reaction, but it's a detail, and especially for a long time use of this. Is there anyone here studying wounds? I think Sergio is doing something on this at this moment, or you finish, Sergio? Sergio's not here?
Here.
Oh, okay. Because you have a big sample size, yeah? And are you doing the randomization and blind studies?
I don't understand you ask, Marcos.
No, I'm asking if you are studying the wounds and dressing on the wounds, and I believe you have a big sample size, and I understood that you're doing the randomization and blind studies. Is it true?
Yes.
I'd like that
yes.
you share, you share a little about your studies.
Yes. Remember this Professor Mashhari, which asked the hand. Remember that. Yes, you can use the same time. First, Jan, amazing your research for work inside bedside. Congratulations. And now here we use two forms for analyzing wounds, static thermography and film thermography in the same time for capture all modified sympathetic actions and study neighborhood inside rooms because temperature and people inside there and others variables is the most important for identifying variables inside the wounds. It's really difficult. For example, if you are open and curative wounds, we need standing by maybe for stabilization inside the wounds from ambient. Or this is really limitation for analyzing because all regions is open hot. It's the sensors need to work up 4 degrees Celsius for analyzing in software. 50 minutes or 20 minutes is the best way for analyzing if remove the curative inside on the wounds. But now we need more investigation for many comprehension different variables inside bedside in wounds. Congratulations, Jan.
Another point is that although we have many different aspects here, and what it this means, it not means that we don't have answer or it's not possible to study this, but it means that we need to focus much more on the statistical power analysis, especially interferential statistics. So maybe big samples, and we must to bring p-values, confidence intervals, effect sizes. So no mind, we have a lot of different aspects, but if we have this p-values, confidence intervals, understand this, we can understand the direction or the aspect of that. And I have another question for Jan, is about the circadian fluctuation, and if you are doing the images in the same time or in the morning or in the same hour, because we know the melatonin and cortisol rhythms can modulate the thermoregulatory behavior. And
Okay,
I think on your study it's very important to
repeat that, please.
Yeah.
Repeat that question.
No, I'm asking if you're taking care to doing the images in the same hour or in the same only on the morning.
Absolutely. Everything was controlled that way. And also we were looking at the first time that we did the study, we went till the patient returned to baseline. Now you would, like Sergio said, in a wound setting, you would not expose the wound that long because you don't want it to lose its own heat and moisture. But what we were trying to establish is how long did that circulation, hold the heat after the dressing was removed to see if there was a difference. But every time that we did the study, there was the exact same time of day in the exact lab. His parameters were all controlled so that there was no variability that way. All the studies were also done in January in Illinois. So you know that it's cold. And so that we were looking at the external temperatures, and we were looking at the relative humidity, and all of these factors. But you have to remember, too, that this study was done initially in 2012, and the final study was done in 2014. We didn't have the availability of the data analysis on infrared camera that we have today. And also AI, you could plug these parameters into AI and probably have more extensive data, but we didn't have that availability.
We have a question from Melina. Please, Melina, go ahead with your question. Welcome.
Okay, thank you for your attention. I'd like to know if there is a student about using CPI, intermittent pneumatic compression, about involving perfusion. We use it very often in intensive care units, and the patients obviously are very, very in a very critical situation, and it could change our quality of care.
Absolutely. One of the things that we have an advantage of today is the development of the near-infrared systems that can now image and also calculate the oxygen content of the tissues. By utilizing both the near-infrared and the long-wave infrared, you could collect the data of oxygen present, in that tissue, how much necrosis, how much exudate, and also the long wave would give you an overall image of the circulation of the total patient.
Okay, thank you.
I'm not sure of your question, but we understand of those. In the ICU units, they usually use contact thermistors to be able to evaluate this. And that was the only way that they were able to do that prior to the development of the new NIR systems that can calculate oxygen consumption through an image.
Okay, thank you. I'm very...
I think Meshari, do you have a question? Please go ahead.
Yes.
Comment.
Thank you, Dr. Crawford, for the presentation, and thank you, Dr. Brioche, for bringing us together and for the lovely song that you posted on the WhatsApp channel. My question is about, I'm wondering, throughout your research, have you used a black body or a fixed heat source to account for the or increase the accuracy of the temperature in monitoring over time?
No, we tried to establish kind of a primitive way that we evaluated changes in temperature. Was we had a water bath that we held at 50 degrees, and we would check the camera before we started, the study in the morning to establish that the camera was actually sensing that, picking up that water bath temperature, and it was accurately demonstrated. But you're talking about an individual lab with limited resources, so we didn't have a static measurement tool that we could do comparisons to.
Thank you so much.
Thank you so much. So we're just in the beginning of this talk. Many news for the future. There are a lot of solutions that will come from many different countries, companies, and sponsors to help Jan on her studies with software, AI, and imaging, 3D, mixing ultrasound, MRI. I know there are some papers coming from Japan and China, very interesting using this. But maybe we can invite them for in the near future. Does anyone have any question? No.
I think it's exciting that we can do 3D modeling now with many of the softwares, and I think that analysis will benefit the field greatly.
Yes, and okay. Okay, thank you so much, Jan. It was amazing, and we expect to see you soon with your results, with your images. And also, please, would you like to invite the people here to take part of AAT? Could you please explain to them about American Academy? So as you are on the Academy much more time than me, please go ahead as a former president.
I've had the privilege of belonging to the Academy now for 25 years. I found that the information that the Academy has in practitioners who are in various fields and the data that they share is invaluable. I felt that belonging to the Academy was very important because it lended credibility to my practice, and also because it is the only truly medical scientific organization that substantiates studies with data and publishing of papers. Many other organizations are owned by camera manufacturers, and so they are biased to that particular unit and performance of that particular unit. The American Academy does not endorse any particular system. What we do is endorse the ability of practitioners to use the technology to improve healthcare delivery and gather information that will benefit the patient.
Yes.
And the Academy is the only way to do that.
So if you're not a member yet, so go ahead, see our website. You will find easily on Google, put in American Academy of Thermology. As a member, you can have special materials, special training, and also taking part of our annual meeting. We are preparing an annual meeting, so soon we have information about that. But you can find some free information on our YouTube channel and also on your Spotify channel. So we have many academic informations on there. And if you want to do training or to have more information, see our website. We have guidelines in different fields, and Jan, most of them, Jan is take part of them. And so we are here open to listen you, to listen your suggestions, and especially to share acknowledgement. We are here to learn with you also, and to listen your experience and your comments and new publications and findings. Thanks so much. Good Saturday, everybody. Thank you, Jan, for these medical minutes. See you on the next Saturday. We will not have medical minutes, but soon I pass a list of all the new invited speakers. Thank you so much. Thank you, Jan.
Thanks, Jenny. Bye.
Bye.